Hello everyone, and welcome to another CME session for ADHD in adults. Our presentation today is late onset and atypical forms of attention deficit hyperactivity disorder, and we're with Dr. Stephen Ferrone, who is Distinguished Professor in the Departments of Psychiatry and of Neuroscience and Physiology at SUNY Upstate Medical University. And on the left here, you'll see Dr. Ferrone. Dr. Ferrone is a principal at ADHD in adults. And on the right is myself, Jonathan Marks, Senior Vice President of Inkwell Medical Communications. This is brought to you by three different organizations. The first is APSARD, which is the American Professional Society of ADHD and Related Disorders. Dr. Ferrone has been a board member of APSARD, and it's a wonderful organization for professionals to learn more about ADHD and comorbid disorders. This presentation is brought to you also by NACE, the National Association of Continuing Education, who accredits our sessions. And this is produced and disseminated by Inkwell Medical Communications, which is my company. And we'll now start the presentation, Dr. Ferrone, so go ahead.
Okay, thank you very much. I will start first with my disclosure slide. I do receive funding from a variety of private sources for either for research or for consulting to them, or for travel to consulting meetings. None of these interests apply directly to the material to be discussed in the program today. So what are we talking about? Well, we're talking about some atypical forms of ADHD. I call them atypical because there are cases of ADHD that don't meet standard diagnostic criteria in our Diagnostic and Statistical Manual, the famous DSM, but yet they apply to people who seem to have ADHD, who have impairing symptoms of the disorder, and it's frequently a difficulty for clinicians to know what to do with them if they have an unusual presentation. We'll talk about late-onset ADHD. These are patients that meet all DSM-5 criteria except the age at onset criterion. And we'll talk about ADHD people who have low and high IQs. There's been some discussion about this, and people saying, for example, that you can't have ADHD and mental retardation. On the other side of the IQ coin, some people say, well, you can't have high IQ and ADHD because ADHD is at its heart a cognitive disorder, so how could you do well on an IQ test?
Steve, just for clarity, the DSM-5 criteria for age, it used to be 7 years old. You had to have it by 7 in DSM-4, and then in DSM-5 it was raised to 12.
That's correct. It was raised to 12 based on research showing that the age of 7 criterion wasn't valid. People who were onsetting between 7 and 12 also had a valid ADHD diagnosis. An important point here, and I'm glad you asked that question, is that the committee chose the criterion of 12 not because it's a magical valid criterion, but because there were no data on patients who onset after 12. So they said, we'll choose 12 because we really don't know what ADHD looks like in people who onset after 12. And we'll talk a bit about that, of course, in the presentation.
Great.
I'm going to talk to you about some research projects that I've been involved with looking at these unusual cases of ADHD. This is our study of late-onset ADHD out of the Massachusetts General Hospital that I've done with Joe Biederman and colleagues for many years. So we're talking here about 3 groups, 2 ADHD groups. One I'll call full ADHD. These meet full childhood diagnostic criteria for the disorder. And then we'll talk about late-onset ADHD. These are people that meet all the childhood criteria except for the DSM-5 age at onset. This is a much smaller group because later ages at onset are less common. Then, of course, we had a group of non-ADHD adults as well to use as a comparison. To validate a construct in psychiatry or psychology, we tend to go through a series of fairly systematic steps. And in this case, we'll use several criteria, one of which is family history. So, for example, we know ADHD is a very highly heritable disorder. In fact, we have a whole presentation on ADHDinadults.com about the genetics of ADHD, where you can learn about that. But because of its high heritability, we can make the following conclusion. If an atypical form of ADHD is truly ADHD, then people who are related to patients who have the full ADHD diagnosis or the gold standard diagnosis, well, they should be at a higher risk for atypical forms. Atypical forms should run in families of gold standard ADHD cases. Another way to test this would be to say that, well, people related to atypical cases should also be at elevated risk for the full gold standard diagnosis. So essentially we're saying if these 2 disorders, meaning full ADHD and atypical ADHD, run together in families, that gives us pretty good evidence that the atypical form is actually real, valid ADHD. So what did we find? So in this bar graph on the left, The red bar refers to probands, which really means patients, the patients that came to our clinic as a proband. We have patients who don't have ADHD, and on the right we have those who had full ADHD. And we're looking at here the risk for late-onset ADHD among their adult relatives. And what you can see is that almost all of the late-onset ADHD is among the relatives of the patients who themselves had full DSM-5 diagnosis of ADHD. This is pretty compelling evidence that this atypical form of ADHD, this late-onset ADHD, is running in families with the full DSM diagnosis. Here we turn the question around. We're now looking at the rates of full gold standard ADHD in the relatives based upon these three categories, either not having ADHD, having the patient having the late-onset ADHD, or the patient having the full criterion form of ADHD. And again, data are pretty compelling. If you don't have ADHD, the risk to your relatives is fairly low. If you have either form of ADHD, either late-onset ADHD or full criterion ADHD, you have a much higher risk. Again, very compelling data that this late-onset form is probably a valid diagnosis of ADHD.
Steve, a question. I can see the strength of the evidence here. In one of those studies that you referred to at the beginning slide, it had an N of 17. That's a small amount. Is that like a pilot study that is showing these kinds of results, or can you make valid conclusions with such a low-numbered study?
Very good question. Let's go back to that slide because it's an important question. So the thing to remember here is that the statistical power of a study, meaning our ability to find an effect, is a function of the sample size in all the groups. Mm-hmm. So even though that one important group is only 17, the other groups are pretty big, 127 and 123, so that gives us substantial power to find something. Mm-hmm. The second point is that when you have a small sample, it does put you at risk for not finding something because it will lower your power compared to, for example, if we had 170 instead of 17. So in that setting, a non-significant finding should be viewed with caution. But in these slides here, I've shown you statistically significant findings, and that wouldn't be explainable by having a small sample.
I see.
So we're pretty confident that these are real findings, the only real caveat being that because the late onset group of patients is only 17, then we're not sure how well this might generalize to other late onset patients. That's something we need to take into consideration.
Right. Good. Thanks for explaining that.
Sure. Another way to validate diagnoses of ADHD is to look at psychiatric comorbidity data. We know that ADHD is comorbid with a number of disorders, social, mood, anxiety, and substance use disorders. We have lots of CME on the website, ADHDinadults.com, to discuss these disorders. But if an atypical form is truly ADHD, well, these people should also be at risk for these comorbidities. Well, are they? So here's the lifetime risk of mood and disruptive behavior disorders amongst our three ADHD groups, not ADHD in red, late onset in yellow, and full criterion in green. The obvious thing here is that for most disorders, the late onset and the full criterion look very much alike and don't differ significantly from each other. By contrast, when you compare them to the red bars, the people who don't have ADHD, their rates of comorbidity are much higher. The only outlier here is bipolar disorder, which was higher, oddly, in the late onset group than it was in the full criterion group, although it was not significant. Mm-hmm. We saw a similar pattern of results for substance use disorders. Again, the yellow and the green bars are fairly similar to each other, except perhaps for drug dependence, although again, that difference wasn't significant. But the important point here is that the yellow and the green bars are both significantly different from the red bar in most cases, especially for alcohol dependence and drug abuse. So again, these data suggesting that the late onset group is following the same pattern that we see for the full ADHD group.
There have been studies by Tim Willens that show the early onset of dependency, and it's particularly higher in ADHD patients. Does the alcohol and perhaps nicotine dependence, do we know, does this show up early in age with the late onset?
It's a good question. What you're saying is correct, is that Tim Willens found was that, and Joe Biederman also, that together that ADHD was associated with an earlier onset of substance use disorders in addition to a greater risk for substance use disorders. So that the kids with ADHD, even if they had a comorbidity, the comorbidity didn't account for all their ADHD, and the ADHD gave them an earlier onset. We haven't looked at that in this data set, so I can't say for sure about that, but it's an important question to look at in future work. We also sought to validate the atypical diagnosis with impairment data. By definition, in the DSM, a disorder is only a disorder if the person is impaired by it. And it's conceivable that somebody could have lots of symptoms and even comorbidities, but without having any impairments associated with their ADHD. So of course we took a pretty close look at that. Here we looked at the patient's history of school functioning. So these are adults reporting retrospectively how well they did when they were youth in school, particularly for, on the far right, for a need for academic tutoring. We can see both ADHD groups had a greater need for tutoring than the non-ADHD group, and those results were highly significant. We found the same pattern for special classes, a little bit lower rates all along, but still significantly different from the not-ADHD group. The results of learning disabilities in repeated grades were less clear, but here again, there is some evidence that these atypical forms of ADHD are showing some problems in youth as they retrospectively report what happened to them in school. We looked at legal problems, did not find significant difference for convictions or imprisonments, but we did find that both ADHD groups were more likely to be arrested than the non-ADHD group. Interestingly, the atypical group had a slightly higher rate of arrest than the full ADHD group. That wasn't significant, but it raised some questions about whether maybe lack of treatment, lack of coming to treatment early made it more difficult for them to stay out of trouble. Because we do know from some very large epidemiological studies that have been done in Sweden that medication has a protective effect on criminality and arrests, therefore, in adults with ADHD. Driving problems are a well-known problem of adults with ADHD. Here we're just looking at having tickets or traffic accidents. And here there's kind of a stepwise effect that the late-onset group had a higher rate than the not-ADHD group, although it wasn't significant, and the highest rates were in the full ADHD group. This next slide is a little complicated, and I'll walk you through it carefully. It's about quality of life in ADHD. First, let's look on the outside. You've got all these different measures of quality of life along these different axes: overall satisfaction, sense of well-being, living and housing, economic status, etc. Now, the way you think of this plot is that people are collapsing into impairment. So if you're on the outside of the plot, like on the red line, you have a lower level of impairment. If you're closer to zero, you have higher levels of impairment. That's why the red line corresponds to not having ADHD, because these people have low levels of impairment. This dark green line corresponds to people who have the full diagnosis of ADHD. They have more impairments. And interestingly, the late onset form of ADHD has even more impairments than the full group. Now, these differences between both of the ADHD groups and the not ADHD group are very highly significant. The two ADHD groups tend to overlap a bit, although the consistency of the impairments in the greater level of impairments in the late onset group is kind of interesting, and it's something we are trying to follow up in future work. But it is very important that these people who come to the clinic who have this unusual late onset ADHD have a true impairing condition. It's not simply that they have lots of ADHD symptoms, they do have real life impairments. Social adjustment is an important aspect of impairment. This is measured by a different measurement than we showed you on the previous slide, something called the social adjustment scale. Again, you see a number of areas of social adjustment on the horizontal axis, and it's the same data layout as you saw in the other histograms or bar charts. Yellow correspond to late onset ADHD, and green to full ADHD. And again, we see the same basic pattern of results. The two ADHD groups, much higher risk for having impaired functioning in all these areas of life. Except, oddly, for parenting. We didn't see any differences in parenting. I would warn you that this is perhaps wrong. Other people have found deficits in parenting associated with adult ADHD. I don't know why we didn't find it. Maybe our measurement was not quite sensitive enough to assess parenting. But there's actually nice literature showing not only do adults with ADHD have impaired parenting, but that when those adults are treated appropriately pharmacologically, that their parenting improves. And that's pretty important for their children, especially because some of their children will also have ADHD.
Steve, can you describe a little bit what late onset is? Are we talking about 17 years old or 35 or 50?
That's a good point, which, yes, I was going to get to that later on in the talk. But in this data set, late onset means after 12. In our sample, it's late adolescence and early adulthood. Okay. So we're not looking at very late onset ADHD. Thank you for clarifying that, because it's important to understand what range we're talking about here. This is late adolescence and early adulthood. And we also look at treatment data to validate atypical forms. the simple algorithm is that if an atypical form of ADHD is actually ADHD, well, then people with the atypical form should respond to treatments that are effective for ADHD. So here I'll look at some published data. This is Joe Biederman's treatment study of adults with late-onset ADHD with methylphenidate. This was an open-label study of 36 patients, so it's not a double-blind, gold standard kind of study. But the results are pretty interesting because, as you can see, a very high rate of improvement on measures of ADHD, either by the Clinical Global Impression Scale, that's the CGI, being much or very much improved, or by reductions in the AISRS, that's the Adult Investigator-Rated ADHD Rating Scale, measures of the 18 ADHD symptoms. And even on the far right, if you look at a definition of improvement based on a CGI score and a reduction in the AISRS, we still see high levels of improvement in this slide between 60 and 70%, which is pretty consistent with what we see for adults having gold standard ADHD. You can see this again in a study by Craig Sermon. This is an open label study, 44 late onset ADHD patients, and one who had subthreshold ADHD but not late onset. And these are reductions in the ADHD symptom score. So they start out with a mean score of about 25, which is pretty heavily impaired. And by the time they get to the end of treatment, they have an average score of about 15. Again, this is open label, but these results are fairly consistent with what you would see in treating adults with ADHD who have the gold standard diagnosis.
Mm-hmm. Steve, I have one question before we go on to this next topic. When we talk about late onset ADHD, is it the same ADHD or are there differences?
Well, what we found in our work so far is that they're pretty similar. There are more similarities than differences. We're not finding, for example, that it's a milder condition, because you saw in that quality of life plot they have substantial deficits in all areas of quality of life, in some cases more than people who have gold standard ADHD. So some people have speculated, and we don't have data that can point to this really, but some people have speculated that people with the late onset form have some strength in their lives that protects them, if you will, from their ADHD. So for example, those strengths, those protective factors could be having parents who have very good parenting skills. Mm-hmm. It could be kids who grew up in well-structured environments. They went to schools that were well-structured and the teachers knew how to handle ADHD. Mm-hmm. They could be kids who were particularly at a high level of intelligence or had some other compensating factor that helped them get through their ADHD. We don't really know. This is really an area of active research to find out what is it that seems to protect some people from ADHD. It also could be biological. We know from twin studies of ADHD that there's evidence that the genes that affect ADHD at different points in the life cycle are not the same. They overlap, but they're not the same at every point in the life cycle. So that, for example, an adolescent, someone onsetting with ADHD in late adolescence, that could be due to a particular genetic makeup they have that predisposes them to onset later in life, or it could be that some of their genes are protecting them earlier in life. Because we have to remember the effects of genes turn on and turn off throughout development. This is also true of environmental exposures, that it's very possible that the person's environment is changing over time, and so early in life we don't see the symptoms, or we don't see at least dramatic symptoms, and then later in life as the environment changes we see more symptoms emerging, and therefore the diagnosis of ADHD. This is all very active areas of research because it's important for clinicians to understand how to deal with these patients. Mm-hmm. Okay, so we're moving on now to talk about ADHD in people of high or low intelligence. Well, relatively little is known about ADHD in low IQ people. This was, I say this based on a review article I did with Kevin Anchel that was published in 2006. We do know that studies that have been done show that low IQ ADHD shows similar correlates as ADHD, so they have the same core symptoms of ADHD. They also have psychiatric comorbidity, and they also respond to the same treatments of ADHD. This is pretty compelling in terms of what we talked about before, about validity criteria. Here's an example of a study by Pearson, et al. In 2000, looking at behavioral symptoms in kids with mental retardation and ADHD versus kids with mental retardation only. And what you see here is that if you have mental retardation, what now we call intellectual disability, you have mental retardation and ADHD, you are more likely to show impairments in all these areas than if you only have mental retardation. But this is very important to those of you who work with mentally retarded adults, the ADHD is adding to their impairments. So it's not simply an expression of their mental retardation, it's actually making them worse, which is a reason why we think it might be true ADHD. The same study was looked at the effects of methylphenidate on these behavioral ratings, and essentially they showed on these different areas of functioning there was a stepwise effect in terms of the dose. So the dose is represented by the different colors, and you can see here that the attention score, the placebo is in purple. Attention score gets better with increasing dose. We see the same thing for hyperactivity, though the way it's measured, getting better means going down on the scale, so it's reversed. These data mean that mentally retarded people are getting better in their hyperactivity with increasing dose. And the same thing for this other hyperactivity scale, and somewhat, but not as dramatically, for this impulsivity scale. Again, an important validation criterion, the treatment of their ADHD is being affected by methylphenidate, which is, of course, very well known to be effective in ADHD. So the short story there is there's good evidence that ADHD is valid in low IQ people. In fact, I just recently completed a study, which is not published yet, looking at intellectual disability and ADHD in a very large sample of twins, and there we show that there's a strong evidence for a genetic overlap between the ADHD and the intellectual disability, suggesting that some of the same genes that are driving ADHD are driving the intellectual disability, which is consistent with what we've said here, that it's a true ADHD, not some epiphenomena of the mental retardation of the intellectual disability. Moving on next to high IQ and ADHD. Well, why is this controversial? First of all, we do define high IQ as an IQ greater than 120. It's arbitrary, but we have to pick a cut point. That's a pretty high IQ. If you have an IQ of 120, you're a pretty smart person. Well, this is controversial. One reason is that many people view ADHD as having a very substantial cognitive component, that it's a disorder of executive functions, it's a disorder of neurocognitive impairment, and so forth. If that's the case, they argue, well, you couldn't have a high IQ and ADHD. Other people say that no, particularly with children, this is also true for adults, that people with high IQ just simply get bored. They get bored because they're in environments that are not very stimulating to them. They're very intelligent. They want to do more, and therefore their boredom leads to their ADHD-type behaviors. That's an epiphenomena of bad environmental setup for high IQ kids. Other studies have shown that high IQ ADHD children do have characteristic symptoms and cognitive difficulties. So we know that these two things go together. So what can we say about this? Well, we did some studies back in 2007. These are just the first set of studies of kids with high IQ at the Massachusetts General Hospital. And here you can see ratings of psychopathology on the child behavior checklist. And what you see in the red are the high IQ kids with ADHD, and the yellow are the high IQ controls. Well, the first thing, the controls scores of 50. 50 is absolutely normal on this scale, and so they look like they should, because they don't have ADHD, they don't have psychopathology. But the high IQ ADHD kids have high rates of psychopathology across the board, just like you would see in an ADHD sample. In this scale here, attention problems is, of course, the highest, because that corresponds to ADHD. If we look at their lifetime history of psychiatric disorders, they're at high risk for major depressive disorder, anxiety disorders, not obsessive compulsive disorder, but oppositional defiant disorder and conduct disorder, just as what you would see for ADHD kids in the normal IQ range. So again, good evidence that they look very much like ADHD kids do with normal IQ. This is their measure of social adjustment. Again, they're in red. Higher levels on this graph mean worse adjustment, and as you can see, they're worse in almost every domain. More evidence that they're not doing well in social relationships with siblings and parents and friends. When we looked at their achievement, we didn't see differences in reading achievement. We did see differences in their math achievement. We also looked at the persistence of ADHD, who got worse over time. It didn't make a difference whether you had high IQ or didn't have high IQ. There was a very high persistence of ADHD 4 or 5 years later. So this is looking at who still has ADHD 5 years after we measured their IQ. It doesn't make a difference. If you have a high IQ, you're still at risk for a persistent course of ADHD in children. If that's true about persistence into adolescence and young adulthood, what about high IQ and ADHD adults? We did some studies of this at the Massachusetts General Hospital as well. These results are for diagnoses on the SCID. The SCID is a diagnostic interview that we use in research. On the horizontal axis, you see many disorders that are frequently associated with ADHD. And the blue line is the high IQ ADHD adults, purple line are the controls, and you can see very large differences between these groups, and they're all significant except this one for simple phobia, and also for Tourette was not significant. But Highly significant differences across the board. A very similar pattern of results to what we would see in a normal IQ ADHD group. And now, I told you earlier in this presentation that familial transmission was one of the validators that we looked at when we were talking about is a condition valid or not. And here we're looking at the risk to relatives for someone depending on whether they have high IQ ADHD, that's the bar on the left, or whether they're controls. As you can see, a much greater rate of familial transmission for the high IQ ADHD adults. And the controls, again, providing more evidence of validity of this high IQ construct. Now, the same was true if we looked at their need for academic tutoring. Remember, these are adults who have a high IQ who are talking about their past. And even though they had a high IQ, they needed to be tutored more than high IQ controls. Because again, remember, these controls are people who also have a high IQ. If you will, the normal high IQ person almost never needs to have a tutor in school. As you can see by that reddish bar being very low. But yet almost half of the high IQ ADHD adults needed extra help. It's clear that their ADHD was somehow impairing them in their academic work, despite the fact that they were very, very, very bright people. Here we're taking a look at their quality of life as adults. You can see the different areas of quality of life on the horizontal axis. It ranges from things like work and leisure time to sex drive and interest to sense of well-being to overall life satisfaction. Let's just take that at the end. The overall life satisfaction is better or greater for the controls than it is for the high IQ ADHD group. And across the board, all of these categories are lower except for sex drive in the high IQ ADHD adults compared to controls. They're all lower. Some of them are not significantly. These two are not significant here. Physical health is not significant, but we are finding substantial and significant quality of life differences between ADHD adults with high IQ compared to control participants who also have high IQs. Now, this slide is perhaps the most interesting because executive dysfunction has been considered a hallmark of ADHD. Well, first, let's define executive dysfunction. Here we're talking about a set of neurocognitive skills that are higher order functions that help us to organize our world, help us to understand concepts, help us to abstract, help us to sequence things in time. These are the higher level skills that are really necessary to be successful in a complicated world. It requires a good deal of organization, the ability to not just organize your life, but to remember how you've organized it, to use that memory to function in the world. What you see on the left are the names of neuropsychological tests that are considered measures of executive functioning. In the blue, you see the scores for the high IQ controls, and higher is better in this graph. And then in the orange, you see the scores for the high IQ ADHD cases. And these are, the ADHD group is doing worse on almost all these measures except for one in the middle here. And all of these p-values are significant except for this one here. The p-values where the adults with ADHD are worse are all significant, even though they're not necessarily large, they're all statistically significant. So again, it's pretty remarkable that even if you have a high IQ, you're still doing worse on these tests of neurocognitive dysfunction. That actually translates into their academic history, which we'll see next. Now, this is the neurocognitive test here. These are tests that were taken when they were adults and they came into our research project. This academic history I'm reporting on this slide refers to their history that they report about how well they did in school when they were in high school and so forth. Well, we didn't see a significant difference for repeated grade. The high IQ ADHD were more likely to repeat grades, but it wasn't significant. But again, it is pretty compelling that 8 people who had a high IQ had to repeat a grade in school, even though high IQ was greater than 120. Very unexpected. But again, the history of tutoring, I think we saw that before from a different perspective. The history of tutoring is much, much greater in the high IQ ADHD group than in the high IQ controls. So they do need more help, despite the fact that they have a high IQ.
In terms of percentages of low IQ and high IQ, and let me just acknowledge first that, years ago, I'm guessing it was thought that ADHD kids were slower, dumber, just because of their poor performance and lack of responsiveness to various stimuli. But now we know that it doesn't have to do with intelligence. So my question is, there's a lore going around. Is there a higher percentage of people who have ADHD and have high IQ?
Actually, what the data show is that on average, people with ADHD have a lower IQ than people without ADHD.
Okay.
Now, that's not a dramatic difference. It's about 9 points. So that's not a huge difference. So it still leaves room for some ADHD people to have very high IQs like we have in this study. It is a real finding. It's been replicated many times now in many, many studies that there is a decrement in IQ for people who have ADHD. So they're not in general smarter than average. I think you are referring to a literature on ADHD being somehow a gift. That
Yes.
symptoms of ADHD lead to special cognitive abilities that make ADHD people do better in life than non-ADHD people. And sometimes people will point to successful people with ADHD, such as I think Richard Branson is an example, and James Carville is an example that people use, and say, you see, you can be successful with ADHD if you just harness it and use it right. And what I say to them is that, these people were probably successful not because of their ADHD, but because of other strengths that they had that they were able to harness, and because of their ability to control their ADHD. And one might even say that they could have been perhaps more successful if they did not have ADHD, although we can't really know that for certain. The main point here is that ADHD doesn't discriminate against people with high IQs or low IQs. It doesn't discriminate against the creative and the non-creative. You can have any skill in the world and also have ADHD. But ADHD itself is not some special gift that makes you do better in life. There's no evidence for that.
Okay.
In a few studies, and no one to my knowledge has ever found something positive that is due to ADHD. So to summarize what we've said about high IQ, both children and adults with a high IQ and ADHD have patterns of familial, cognitive, psychiatric, behavioral, and functional features that are totally consistent with the diagnosis of ADHD that we see in average IQ people. This pattern is no different and really makes us conclude that it is valid to diagnose ADHD in people who have high IQs. Put differently, you shouldn't discriminate against high IQ people and say, no, you don't have ADHD because you have a high IQ, because you're a bright person, because you've been successful. Doctors should not discriminate against people who have high IQs when they're making a diagnosis of ADHD. They need to apply the same diagnostic criteria for ADHD, make sure the person meets the symptomatic criteria, shows evidence of impairment, and so forth, and then apply the diagnostic criteria as they would someone who has an average IQ. Now, let me summarize what we've said overall about these atypical forms. First, there's clear evidence for the validity of ADHD in some people who onset in the disorder after the age of 12. And as we said earlier, this is between the age of 12, in late adolescence and young adulthood. We don't have data in this study to talk about later onsets. And we mentioned that both low IQ ADHD and high IQ ADHD appear to have fairly strong evidence for validity. It's stronger for the higher IQ group because there's really more data available. But I would not, again, discriminate against anybody with either low IQ ADHD or high IQ when making the diagnosis, because if you do so, it denies people treatment who may really need treatment and which may really help them. Let's talk about some diagnostic issues for late onset adult ADHD that have become particularly important in the recent year or two. Well, first, there are some thorny issues in making the diagnosis, and one of them is that the recall of people with ADHD is not always the best. So if you're talking to a patient in your office, you typically don't have access to their parents to ask about their childhood, and you probably don't even have access to their spouse who maybe knew them as a child or could tell you about what they've heard about them as a child. And so you have to rely on the patient with ADHD. Unfortunately, people with ADHD have not such good recall, and so not likely to recall all their symptoms. In fact, there's some good research that literally shows that. When you do follow-up studies, where you start with kids who have documented ADHD in childhood, you follow them up as adults, and as adults, you ask them about their childhood. What you find out is that they don't recall their ADHD symptoms. One has to be careful that, because what this means actually, that sometimes what appears like a late onset ADHD might really be a childhood onset that's just difficult to document because the data are not available. If you have access to a parent or to a significant other in the patient's family, by all means try to get information. Sometimes it's not so hard to get if you give them a simple rating scale, send it through the mail, have the patient bring it to them. It can provide useful data. In some cases, the late onset people just might have a less severe case of ADHD. They had mild ADHD that was not a problem early in life, but as life got difficult, as life becomes less structured and more complex, then that challenges their ADHD and the symptoms start to emerge. So for example, you do tend to see ADHD complaints emerge during transition. So for example, a woman who just had a child and now has to take care of it at home, that's a time where there's kind of an increased likelihood of somebody complaining about ADHD symptoms because the complications of the environment are now stressing their executive system, stressing their frontal lobes. They can't compensate as well, and they start to decompensate, have impairments, and may seek help. Some cases of late onset ADHD in adults might correspond to situations where, as children, these adults had supportive and well-structured home and school environments. And if you may detect that in somebody who has late-onset ADHD, and it could just mean that their ADHD was masked by these very protective environments, that in fact they were getting really good psychosocial treatment because of the way they were raised. There's other possibilities, for example, compensation for symptoms. Patients may have compensated in other ways for their symptoms as youth and adolescents. And there may have been self-medication. There are some adolescents who start to smoke, for example, because nicotine is not a very good pharmacologic treatment for ADHD, but it has been shown in some clinical trials to treat ADHD symptoms. So self-medication with nicotine, or in some cases cannabis, may explain why symptoms are not evident during youth. So late-onset ADHD, complicated diagnostically, but you can get through it and you can provide these people with a good deal of help. Now, there's been a very big controversy in the field just this year about the question, can ADHD onset occur in adulthood de novo? And in this case, some of these people who were writing about this were talking about de novo onsets very late, in the late 20s and by the age of 30. It is a complicated question. We can't go into all the details in this short presentation. I do refer you to this editorial that I wrote with my friend and colleague Joe Biederman in JAMA Psychiatry. And here we basically say that we have to be very suspect about these claims for adult onset ADHD. A lot of it has to do with some of the specific details of these individual studies and how they were run. The other has to do with probably the main mistake that these studies made was that they didn't adequately assess the presence of subsyndromal forms of ADHD in youth. And in fact, when in many of these, if you look at the details of these studies, what you find out is that many of these so-called adult onset cases actually had signs of the disorder when they were young, that they were picked up by these people who wrote the papers and reported, but they weren't considered ADHD, so they just find them as not having ADHD. So in a way, what these studies suggest is that these people coming into these research projects that appear to have very late onset ADHD actually have had a subthreshold form of ADHD in childhood, and that wasn't brought into treatment, and they only emerged as adults with ADHD because of events that occurred in adulthood. The conclusion of our editorial was that doctors shouldn't ignore adult onsets as being valid, but they should be pretty cautious. The later the onset of the disorder, the more cautious you should be in diagnosing it. It's probably the best way to describe that. And the way to show caution is to try to get reports from significant others, which would be helpful. Try to get better reports for how they were as youth, and do a more careful diagnostic interview than you might do for the average adult with ADHD.
Steve, let me ask a question here at this point. We know that today, based upon the more recent discoveries of continuation of ADHD in adulthood, we know that about 90% of ADHD adults are both undiagnosed and untreated. So my question is this issue a fact of late diagnosis, or is this late onset?
That's a really good question. Partly it's an issue of the later onset, that the people who have the late onset form, because they weren't treated as children, the treatment wasn't carried over into adulthood. Partly it's a little bit historical, so that adult ADHD was, for example, in the 1960s it didn't exist. Nobody studied it. People didn't think it existed. Theories of ADHD said ADHD remitted completely in adulthood, and you couldn't really get treatment. It wasn't until the early 1990s that myself and colleagues began to study adult ADHD. It started with Paul Wender, actually, in probably the 80s. He was a real pioneer in this area. We realized that ADHD did persist into adulthood. At that point, hardly any adults were treated, and there was no way to get treated. Psychiatrists didn't know how to treat them because they weren't trained in adult ADHD. Primary care doctors had no conception of adult ADHD. So back in the 1990s, the only way you could get treated for your adult ADHD is if your pediatrician would let you continue on your meds and see you, which was rare, or if you could get an appointment with a child psychiatrist who was a specialist. And many adults with ADHD were actually treated for a while by child psychiatrists. Now that situation has improved a lot, but there are many adults who actually had ADHD as children, and they stopped their medications, and then because they were told they couldn't have it when they were older, and then they're currently untreated. So yeah, it certainly is a big public health issue. And there aren't enough psychiatrists to treat the adults with ADHD, which is why we have set up this website for training primary care practitioners about adult ADHD, because these are the people that are in the front line and really have to handle the lion's share of the work of treating the adult ADHD population. A little bit more to say about diagnostic issues for low IQ people with ADHD. This is actually pretty tricky because in the DSM, if you look at the diagnostic manual carefully, it requires that the symptoms of ADHD are excessive for the person's mental age. Well, this is a problem because it can really be difficult to figure that out, especially for adults. If you have an adult with very low IQ, you have really no way of knowing whether their ADHD is excessive for their mental age or not. So I actually advise people not to use that rule because I think it's so ill-defined. Even for kids, it's ill-defined.
Mm-hmm.
Although it can be easier to do for kids, but for adults it's almost impossible. So my advice is to essentially document that the symptoms of ADHD are leading to impairing behaviors. And that just involves asking the person about the ADHD symptoms, and as you ask about those symptoms, find out what they do in their life, what those symptoms do to the person in their life that is actually impairing in some way. And keep in mind that impairment is multi-situational. It should occur in more than one setting. ADHD does not cause impairments only with relatives or only in school or only on the job or only when you're playing sports. It impairs you all the time. So you should be able to show impairment in more than one setting to make the diagnosis. That applies for low IQ ADHD and really all cases of ADHD. Now, for high IQ ADHD, there's no DSM requirement that the symptoms are excessive for mental age, which is kind of odd. I say should it because it's kind of odd that they can be excessive for low IQ but not high IQ.
Mm-hmm.
This raises the question about how one defines impairment. So there's really two ways to do it. You can say, well, someone's impaired if they're worse than most people on something. Or you can say that no, someone's impaired if they're not doing as well as they should based upon their potential. And that's what we mean by impairment being defined as a gap between potential and performance. So the problem that people who have high IQs is that because they're doing very well in life in general, some people see them as not impaired. So I'll give you an example. Take somebody who's a partner in a law firm. They've done really well in their life, and they learn about ADHD, and they say, my gosh, that's me. I'm like that all the time. I've been that way for the last 15 years. And they go talk to their doctor. Well, some doctors will say, well, you're a partner in a law firm. You make loads of money. You've done very well. Your colleagues applaud you. You can't have ADHD because you're not impaired. You're not showing overall general impairment in your life. Well, my answer to that particular quandary is that doctors should, first of all, try to get a sense of, is there any evidence that this person may have done even better if they didn't have ADHD? In other words, is there a gap between their actual performance and their potential? I would tell this doctor, assess their compensatory behaviors. Is this person doing well because they have to work a lot harder than everybody else? So maybe this guy is putting in 12-hour work days where everybody else is putting in an 8-hour work day. Mm-hmm. He has to put in 12 hours to keep up with the rest of the successful lawyers. Mm-hmm. Does he avoid, or does he or she avoid specific tasks that require concentration or require them to be sedentary, sitting at a desk for long periods of time? Also look at compensatory resources again. Well, high intelligence is one of them, and that is look in terms of the gap between high intelligence and their performance, and creativity is another compensatory resource that they might have applied to their life. You also can look at, if you have time in your diagnostic procedure, look at their compensation when they were younger. So I had a lawyer I treated once, and when he was in law school, I asked him, well, how'd you get to law school if you're having such trouble now? Well, in law school, he literally spent most of his time in the library where it was quiet, where there were no distractions, where his ADHD couldn't bother him. And that was a compensation. It was like treating his own ADHD. When he went out into the real world, he couldn't do that. He had to deal with the real world of distractions, and that just totally decompensated him into having a full-blown case of ADHD.
Steve, let me share a kind of humorous example about that. We interviewed an attorney, and he's very successful, and he's been successful throughout his life. But early in his career, he started in the Bronx Public Defender's Office, and he said it was tailor-made for somebody with ADHD because it was crisis management the whole time, and he performed brilliantly. And it was when he decided to go into private practice where he had to start managing more of his own business development and keeping track of things. This is when the ADHD symptoms or impairments really started to become obvious, and that's when he got diagnosed, when he went into his own private practice.
That's a perfect example. ADHD people frequently can do much better if they're in an environment where somebody is telling them what to do, where it's very well defined, where it's kind of high energy, like it would be in a public defender's office. You're going from one thing to the next, and you have to move quickly and get things done. And more importantly, someone's saying you have to do this, and this is the due date, and I'm on top of you to make sure it's done. But yeah, you enter a private practice and you're expected to just organize your life on your own, not to have your hand held by the other partners. So yeah,
Right.
that's a good example of this situation. Let's talk a little bit more about atypical ADHD. The DSM tells us that ADHD symptoms must cause clinically significant impairment, but gives you very little guidance otherwise. And this gets us back to this kind of absolute and relative business of how you define impairment. So is it absolute, meaning are you in the lowest 5% of the population? Is it relative to your IQ? That's the gap we talked about before. Or is it relative to some other index of ability? Is it relative to your educational cohort? How much schooling did you have? Is it relative to how much resources you happen to have? Did you come from a wealthy family? Or did you come from a poor family? These are not defined in the DSM, and it's left not just to primary care doctors, but also to psychiatrists and psychologists to make this decision really on their own. Another important issue has to do with defining impairment for diagnosis and defining impairment for what I call resource allocation or accommodation decisions. Now, these are two very different things, and you may not get involved in this in primary care, but you may also be involved in this, where somebody is looking for their diagnosis as a way to, for example, get accommodations in college. Because if you have an ADHD diagnosis, then you get more time for taking tests, as one simple example. And there are other advantages you can have if you have a diagnosis of ADHD that give you some accommodations or give you more resources in academic settings or in occupational settings. So that decision is different than the decision of whether someone has a diagnosis of ADHD, because sometimes the decision about accommodations has to do with the absolute level of impairment, and that's more of a, if you will, a medical legal decision as opposed to just a medical decision. So just keep in mind that somebody can have a diagnosis of ADHD even though, and they might be told they don't qualify for specific accommodations in the work environment or the school environment. All right, quick summary. If you have learned anything from this talk, it should be that these atypical forms of ADHD show considerable evidence for validity in the sense that they are valid variable forms of ADHD that probably share the same risk factors and neurobiological features with the gold standard form of the disorder as diagnosed in the DSM. And perhaps more importantly, diagnosing these atypical forms in clinical practice does require caution and a comprehensive assessment of impairment. Can't emphasize how important it is to show that the ADHD symptoms are causing impairment in the person's life. And with that, I say thanks for listening.
Great, Steve. So I want to thank Steve Ferrone very much for presenting this atypical ADHD presentation. We've learned a lot about low and high IQ and also about late onset. Dr. Ferrone is Distinguished Professor at SUNY Upstate Medical University, and he's also the Program Chair for ADHD in Adults. This has been Jonathan Marks with ADHD in Adults, and again, we're a partnership organization with APSARD, the American Professional Society of ADHD and Related Disorders. It's a wonderful organization that has its annual meeting every January. We're accredited by NACE, the National Association of Continuing Education, and this presentation is brought to you and distributed by Inkwell Medical Communications. Thanks everybody for being with us. We'll see you again.